we talked about anemia, and now we're going to talk about a few other blood dyscrasias. And sort of as a theme for the rest of the quarter, we're not going to talk about every pathology that's in the textbook. We're just going to hit the highlights. So the first one we're going to talk about, well, first of all, the learning objectives. Compare the different types of leukemia in terms of onset, incidence, course of the disease, etc. There's a lovely chart for that. I like that. I want you to kind of know what hemophilia A is, its pathology, signs, and treatment, and what are the cellular presentations of the different types of leukemia. So leukemia is sort of the main other blood dyscrasia besides anemia that you hear more about, and clotting disorders like hemophilia. There are a couple other ones that we'll just hit on, but we're not going to talk about every one that's in the book because there are a lot of them. So polycythemia is one of them. So primary polycythemia, or it's also known as polycythemia vera. Vera means true in Latin. It's a condition where there's an increased production of erythrocytes and other cells in the bone marrow. It's a neoplastic disorder. So remember when we talked about neoplasms, neoplasm is a new growth. So it's serum erythropoietin levels are low, but for some reason, the body is creating more red blood cells. Secondary polycythemia or erythrocytosis, remember erythrocytosis is increased numbers of erythrocytes. It's an increase in red blood cells that occurs in response to prolonged hypoxia and increased erythropoietin secretion. So it's a compensation mechanism to provide increased oxygen transport. If you go to like the Andes or Tibet and you're a lowlander or a sea level person, you will probably get secondary polycythemia as a response to decreased oxygen levels. So I saw this really interesting lecture a long time ago, like 20 years ago, where somebody was talking about the different types of compensatory mechanisms in people that live in the Andes versus people that live in Tibet. And there are different ones. But if you go from sea level to the Andes, secondary polycythemia is a compensation mechanism to provide increased oxygen transport. Interesting, right? So the signs and symptoms are distended blood vessels and a sluggish blood flow. Obviously, that's a sign, not a symptom. Increased blood pressure, hypertrophy of the heart, hepatomegaly, which is increased size of the liver, splenomegaly, which is increased size of the spleen, dyspnea, headaches, visual disturbances, and thromboses and infarctions. The patients are plethoric and cyanotic. So that's a deep reddish blue tone to the skin, and you get engorged blood vessels in the mucosa. That's a symptom of the sluggish blood flow. Just as a result of the increased blood pressure, when you take someone's pulse, it's full and bounding, and like you can really feel it. It's bounding. The thromboses and infarctions can really have a huge effect. It can affect the extremities, the livers, the kidneys, as well as the brain or the heart. So obviously that's not a good thing. When you're looking at diagnosis, all cell counts are increased. You get increased hemoglobin and hematocrit because you have more cells in the blood. Hematocrit is the percentage of cells in the blood. Makes sense. More hemoglobin because you have more red blood cells. Hypercellular bone marrow, meaning extra cells in the bone marrow, and hyperuricemia, which is you get more uric acid in the blood. That's a result from cell destruction, and that can lead to joint pain. So high levels of uric acid is one of the effects of gout, which leads to joint pain. So it's sort of like another road to gout. There's different cause and treatment for gout. The treatment is you identify the cause. So if the cause is that you went to the Andes, the treatment is to go down from the Andes. So that's what I heard. Sometimes people call it altitude sickness. I heard one mountaineer say there are 3 treatments for altitude sickness. go down, and go down. So if high altitude is causing it, then get rid of the high altitude. If something else is causing it, you might need drugs or radiation to suppress the bone marrow activity, and periodic phlebotomy to remove the excess blood cells. So they take blood because you have excess blood cells. So kind of interesting. There are lots of different blood clotting disorders, and they all have similar signs but different causes. So the main one we're going to talk about is hemophilia A, but the other types of blood clotting disorders have similar signs. Okay, so spontaneous bleeding or excessive bleeding following minor tissue trauma are the signs. Persistent bleeding from the gums, repeated epistaxis, which is nosebleeds, petechiae, which are those pinpoint flat red spots on the skin and mucous membrane. So this is a photograph of petechiae. Frequent purpura and ecchymosis, and that's the look of bruising when you didn't have any trauma. More than normal bleeding in trauma. So like you get a paper cut and you bleed and bleed and bleed. So that's more than normal. Bleeding into the joint, which is hemarthrosis, swollen, red, and painful joints. That's what bleeding into the joint causes. And hemoptysis, which is coughing up blood. None of that stuff's good. We know that. So this is a picture of an ecchymosis. Looks like a bruise, very deep bruise, but it's caused from internal bleeding. More signs of blood clotting disorders include hematemesis, which is coffee ground emesis, sometimes they'll call it. It's coarse brown particles in the in your vomit. Emesis is vomit. So the coarse brown particles are little clots of blood, is what they are. Blood in the feces, either black or occult. Occult meaning you can't see it, but you can see it under the microscope. You can't see it with your eyes. Anemia, because your blood is not in the right place. Feeling faint and anxious because of that sympathetic nervous system response. Low blood pressure, because again, your blood's not in the right place. And rapid pulse, because we're trying to get oxygen to the rest of the body. So hemophilia A is what's called classic hemophilia. It is a genetic disorder. It's a deficit or abnormality of clotting factor 8. So the gene that codes for clotting factor 8 is defective in hemophilia. It's the most common inherited clotting disorder. It's an X-linked recessive trait, meaning it's manifested in men and carried by women. So if you're, the way that it's going to be manifested is if you're homozygous recessive for that gene. If you're heterozygous recessive, you are a carrier, and if you're homozygous dominant, you don't have it. It varies in degrees of severity. Usually it's detected because of prolonged bleeding after minor tissue trauma. It has spontaneous bleeding in joints, just like other forms of hemophilia, and possible hematuria, which is blood in the urine or blood in the feces. It's diagnosed by those bleeding time tests, the PT and PTT times. Serum levels of factor 8 are low. There's a drug treatment called desmopressin that is used to treat hemophilia A, and there's also replacement therapy for factor 8. So another group of dyscrasias that is very common are the leukemias. And the leukemias are a group of neoplastic disorders, meaning new growth cancer, involving white blood cells. So it's uncontrolled white blood cell production in bone marrow or lymph nodes. So because your bone marrow and lymph nodes are creating so many white blood cells, other hemopoietic tissues are reduced. So you're not creating other blood cells because you're spending all your time creating white blood cells. One or more type of leukocytes are undifferentiated, immature, or non-functional. So that is a huge problem because we know that our lymphocytes or leukocytes do a lot. And so just like in a lot of cancerous tissues, I mean, leukemia is a type of cancer, um, where the cells are reproducing so fast, they are undifferentiated and immature, and so they lose their function. Large numbers of these undifferentiated, immature, non-functional cells are released into general circulation, and they infiltrate the lymph nodes, spleen, liver, brain, and other organs. This is a huge problem. There are lots of different types, several different types of leukemias. Some are listed as acute, some are listed as chronic. So as you can understand, the acute ones are sort of more dangerous or more exigent. I don't know the right word. They're acute, and the chronic ones you live with. So the one that is the primary age group, it was mostly adults, except for young children with acute lymphocytic leukemia. The B lymphocytes are affected, so naturally it affects the immune system. It does respond really well to treatment, so yay. That's ALL, acute lymphocytic leukemia. Acute myelogenous or myelolytic leukemia, AML, the granulytic stem cells are affected. So that affects all of the cells resulting from those, and it's in adults. And we'll talk about each one of these, but this is a nice little comparison. Chronic lymphocytic leukemia, CLL, affects B lymphocytes. And it usually manifests in adults greater than 50 years. I've worked with people with CLL. I was working with them for other issues. Sometimes you don't know you have CLL until you get a blood test for something else and it shows up. So that's what people I've worked with have told me. They said, oh, I was getting tested for this and this showed up. So there aren't a lot of symptoms associated with it. Chronic myelogenous leukemia, CML, again, it's the granulocytic stem cells that are affected. It's adults 30 to 50. Acute monocytic leukemia affects monocytes. So, of course, monocytes turn into macrophages, and that affects the immune system and healing, lots of things, and adults are primarily affected. And hairy cell leukemia affects B lymphocytes, and it's generally in males greater than 50 years. So acute versus chronic leukemias. The acute leukemias, ALL and AML, have a high proportion of immature non-functional cells in the bone marrow and in the peripheral circulation. So like anything that's acute, it has abrupt onset, marked signs of complications, occurs primarily in children and younger adults, and it's definitely life-threatening. Chronic leukemia, CLL and CML, there's a higher proportion of mature functional cells. So that's why you can function with it over the years. It's an insidious onset, mild signs, and a better prognosis, and it is common in older adults. So acute, severe signs, not as good a prognosis. Chronic, mild signs, and a better prognosis. So acute leukemia at onset, usually frequent or uncontrolled infections. That makes sense, right? Since the B lymphocytes or the stem cells of the white blood cells are affected, that makes sense. Petechiae and purpura, that's one of the signs. And the classic signs of anemia, fatigue, pallor, tachycardia, dyspnea. Severe and steady bone pain, that sounds awful. Weight loss, fatigue, and possible fever. Enlarged lymph nodes, spleen, and liver, because they're busy processing all those extra cells. Headache, visual disturbances, drowsiness, and vomiting. And sudden onset of that. For treating leukemia, they usually do blood smears to look for immature leukocytes and altered number of leukocytes. There's decreased numbers of erythrocytes and thrombocytes because the bone marrow is just going crazy making leukocytes. And usually they do a bone marrow biopsy for confirmation. It's treated by chemotherapy. ALL in young children responds well to chemotherapy drugs. So yay, that's good. Biological therapy, interferon, is sometimes used to stimulate the immune system to make up for the loss of those cells. So there is treatment for leukemia, and actually it's a lot better than it used to be. The survival rate for leukemia used to be like 5%, and now it's 90%. So much better treatments. Cancer research has really paid off in the area of leukemia. The complications of leukemia are opportunistic infections, including pneumonia. Pneumonia is going to get a lot of people in the end. Sepsis, that's going to get the people that pneumonia doesn't get. Congestive heart failure, yeah, that's a problem. Hemorrhage, liver failure, renal failure. You can't live without your liver. You can't live without your kidneys. Central nervous system depression and coma, yes, those are serious things. So serious complications, you need to be treated as soon as possible to get a better prognosis.